Swadikrat, I'm Dr. Chuck with CMC. So today we're going to continue with medical tutor. And the last med tutor video we did cranial nerves, right? We did cranial nerve 1 and cranial nerve 2 the last time. So last time we did the olfactory and the optic nerve. Today we're going to continue with cranial nerve 3, 4, and 6. So 3 oculomotor, 4 is trochlear, and 6 is abducens nerve. We're going to leave cranial nerve 5 for the next tutoring video. What is cranial nerve 5? Trigeminal nerve, right? We're going to leave that for the next one. Today, 3, 4, and 6. These cranial nerve is all about the eye, right? The movement of the eyeball and also the constriction of the pupil and accommodation. Accommodation is like, for your lens to focus appropriately, especially when you read something close. That's accommodation. So these cranial nerve control the extraocular muscle and also the intraocular muscle. Intraocular muscle controls the pupil constriction and the accommodation. And as always, I like to do this video in the English language. And I hope that it's been helping you guys, especially you guys who are studying for your board exam. And as I said many times, that English is a universal language of medication. So that's why I'm doing this video in English. And I know you guys are tired of hearing me saying this, but I'm going to say it anyway because I think the most important aspect of medical education or medical science study is having support from your peers and your professor and having someone there to tell you that, hey, you can do this, you can get through this. I remember when I was a medical student, my professor used to tell me all the time, hey, Chuck, medical science takes very little brain. Medical science, you don't have to be the smartest guy, but you have to be the most disciplined guy. You have to have good studying skill, and you just got to be disciplined in your studies. And I'm passing this on to you guys, I guess. And don't forget to do your Q banks, right? When you do your Q banks, that's repetition of what you've learned, and that's going to help you bring what you've learned into your long-term memory. And as always with this video, I'm going to be concentrating on the clinical relevance and concentrating on, what they like to ask on the board exam, such as the USMLE. Okay, so let's start with Cranial Nerve 3, the oculomotor nerve. And Cranial Nerve 3 have two main functions, right? So one of the function is to move your eyeball in certain direction. And that is achieved by Cranial Nerve 3 innervating certain extraocular muscle to pull and contract your eyeball, to move your eyeball in certain direction. And the second function of Cranial Nerve 3 is to provide parasympathetic fibers to some of the intraocular muscle of the eye. So that's going to provide through parasympathetic motor neurons, right? That's going to make your pupil constrict, and also it's going to innervate like a smooth muscle of your eye, like ciliary smooth muscle of your eye, to be able to make the lens of your eye change shape and to accommodate when you read something close, your lens going to change the shape so you can see better when you're nearsighted. So there's two main functions of oculomotor nerve. One is to make your eyeball move in a certain direction, and the second function is pupil constriction and also accommodation. And as I said in the last video, Cranial Nerve Part 1, that Cranial Nerve 3, the oculomotor, is involved in pupillary light reflex as well. And you may remember me saying this, that pupillary light reflex is Cranial Nerve 2 and Cranial Nerve 3 working together. You can see from the last video I explained this a little bit, but basically Cranial Nerve 2, the optic nerve, is involved in the afferent limb of the pupillary light reflex. That's basically telling your brain that, there's a lot of light coming through the eye right now, and the brain says, okay, we have to adjust our pupil. We have to make sure the pupil constrict a little bit to make sure the light doesn't shine through very brightly into our brain. So that part is called the efferent limb of the pupillary light reflex, and that's by cranial nerve 3. So cranial nerve 2, when the light's coming to the eye, cranial nerve 2 is telling our brain that bright light's coming through, and cranial nerve 3 is the response. Cranial nerve 3 is telling, hey, the light, we understand that the light is so bright, so cranial nerve 3 is going to send a signal to our pupil and telling our pupil to constrict, and that's the efferent limb of the pupillary light reflex. So this is two cranial nerve working together, cranial nerve 2 and cranial nerve 3. Cranial nerve 2 basically telling the brain that there's a lot of light. Cranial nerve 3 is telling ciliary smooth muscle of the eye to constrict the pupil, to kind of like dim the light a little bit, and that's how it works. So there's two types of fibers involved with cranial nerve 3. One of the fibers is called the general somatic efferent fiber. What is that? General somatic efferent fiber is the fiber that controls the skeletal muscle of the eye. Basically, this type of fiber is ordering your extraocular skeletal muscle of the eye to move your eyeball in a certain direction. And the other fiber is called the general visceral efferent. General visceral efferent basically is the fiber involved with the parasympathetic innervation, like parasympathetic motor neurons. So these kind of fibers will innervate your smooth muscle in your eye, and this will make your eye be able to constrict and make your eye be able to accommodate when you read something close. So that's two types of fibers. So general somatic efferent, that's movement of the eye, and general visceral efferent, that's the parasympathetic motor fiber, and that controls the pupil constriction and also the accommodation. So how does oculomotor nerve or cranial nerve 3 leave your brain and enter into the eye socket? Well, the nucleus, the cranial nerve 3 or oculomotor nucleus is located in your midbrain, right? and beside your oculomotor neurons, you're gonna have the parasympathetic nucleus also. The parasympathetic nucleus that's beside the oculomotor nucleus is called the Edinger-Westphal nucleus, and this is a parasympathetic fiber. So, and this parasympathetic fiber is going to run along with your oculomotor nerve. So now your cranial nerve 3 leaves your midbrain. Your cranial nerve 3 is running along with your parasympathetic fiber. Remember, they run close together. And your cranial nerve 3 will run between two arteries. And this has some clinical significance, which I will explain in the end. But above your cranial nerve 3 is the posterior cerebral artery, and below your cranial nerve 3 is the superior cerebellar artery, and your cranial nerve 3 run between these two arteries, and that's a clinical significance, which I will explain in the end about these two arteries being between the cranial nerve 3. So cranial nerve 3 run between these two arteries as the cranial nerve 3 exits the midbrain, and then the cranial nerve 3 goes into the cavernous sinus, and actually runs on the lateral wall of the cavernous sinus. And also there are other structure that runs along the lateral wall of the cavernous sinus, and that's cranial nerve 4, your trochlear nerve, and also two branches of your trigeminal nerve runs along the lateral wall of cavernous sinus as well, and those nerves are V1 and V2, so ophthalmic nerve and maxillary nerve. So what goes past the lateral wall of the cavernous sinus is your cranial nerve 3, cranial for your V1, which is ophthalmic nerve, and V2, your maxillary nerve. Those are from the trigeminal nerve. And also, something else is in the cavernous sinus, but it doesn't run along the lateral wall, which is your internal carotid artery, and also your cranial nerve 6, your abducens nerve. Cranial nerve 6 also goes through the cavernous sinus, but it doesn't go through the lateral wall. So you can see that there's a lot of traffic in the cavernous sinus, and that's going to be, major clinical relevance in the end about the cavernous sinus, and I will explain all that. So basically, Cranial Nerve 3 leaves the midbrain, runs between the two arteries, and enter the cavernous sinus through the lateral wall. And as the cranial nerve 3 with the sympathetic fiber exit the cavernous sinus, it exits the brain, it exits the skull through a very little foramen. And that foramen is called the superior orbital fissure. So the superior orbital fissure. And that's where the oculomotor nerve leaves your skull and enter your eye socket. And superior orbital fissure is very important for your lab exam, and as I explained in the previous video, that the foramina and the fissures that the cranial nerve exit the skull are very significant in the lab exam, and usually your lab in your lab exam they're going to tag certain foramen or certain fissure and ask you what structure passes through, and they could tag superior orbital fissure, and they could ask you what artery passes through, or what's the function of cranial nerve 3. So these sort of things. So you have to be able to identify superior orbital fissure on your lab exam. So what structures passes through the superior orbital fissure? That's 9 of them. So 9 structure passes through the very little hole, and you have to know them, right? So you have the frontal nerve, you have your lacrimal nerve, and you have your nasociliary nerve. These 3 nerves are actually branches of your trigeminal nerve. These 3 nerves are V1, branches from the V1 of your trigeminal nerve. So frontal, nasociliary, and your lacrimal nerve. And next you have your trochlear nerve, cranial nerve 4. You have abducens nerve, cranial nerve 6, and you have your cranial nerve 3, but you have 2 branches. You have your superior branch of your oculomotor nerve, and you have the inferior branch of your oculomotor nerve. So superior and inferior. And then next you have some veins. You have your superior ophthalmic vein, and you have your inferior ophthalmic vein. So these 9 structures passes through the little hole of superior orbital fissure and enters exit the skull and come to your orbit. And you have to know these 9 structures, and you have to be able to identify superior orbital fissure for your lab exam. Okay, so your cranial nerve 3 exit your superior orbital fissure and enter the eye socket. So what happens next? So your cranial nerve 3 actually splits into 2 divisions, the superior division and the inferior division, right? And now we're gonna forget about the parasympathetic fibers right now. We're just gonna concentrate on the general somatic efferent fiber, the fiber that control the skeletal muscle, the fiber that control the movement of the eyeball. We're gonna forget the parasympathetic fiber right now. So with that, let's concentrate on the superior branch of the superior division of the oculomotor nerve right now. So the superior branch of the oculomotor nerve will supply 2 muscles, right? One muscle is the levator palpebrae superioris. So this muscle the function is to keep the eyelid from drooping, right? It's to keep the eyelid from drooping like this. So that muscle is the levator palpebrae superioris, and that is supplied by the superior branch of the oculomotor nerve. And another nerve that the superior branch supply is the superior rectus. The superior rectus is a muscle attached up top of your eyeball, and when that contracts, the muscle pulls the eye upwards, so it elevates the eyeball. It elevates and rotates the eyeball upwards, right? So the function of the superior rectus is to elevate and adduct the eyeball. So up, the eyeball goes up and inwards. So elevation and adduction. So what about the inferior branch of the oculomotor nerve? The inferior branch of the oculomotor nerve supplies three muscles of the eye: the inferior oblique, the inferior rectus, and the medial rectus. So the inferior oblique kind of touches the eye like on the lateral side and on the bottom, and when it contracts, it contracts kind of in a funny way, because when it contracts, it kind of pulls forward a little bit. So when the inferior oblique contracts, it elevates your eye up, and your eyeball move like on the lateral side. So your eye goes up, your eye go up and out during inferior oblique contractions. So your eyes elevate, and that's an abduction, up and out. So up and abduction, right? And the inferior rectus, right, it's on the bottom, and when it contracts, it kind of depresses the eye, pulls the eye down, and adduction as well, so down and inward. And the medial rectus attaches the eye on the medial side, and when it pulls, it's adduct the eye, so adduction. So moves the eye medially, so adduct like that, right? Adduction. And that's the three function of the three muscle that is supplied by the inferior branch of the oculomotor nerve. Okay, so now coming to the parasympathetic fiber or parasympathetic innervation for the cranial nerve 3. Remember that the parasympathetic fiber runs along with cranial nerve 3 very closely, to cranial nerve 3 all the time. And when cranial nerve 3 exits superior orbital fissure, it turns into two division, right? The superior division of cranial nerve 3 and the inferior division of cranial nerve 3. So the parasympathetic fiber runs along with the inferior branch of cranial nerve 3. So parasympathetic fiber runs on the inferior branch of cranial nerve 3, and then it goes into a ganglia, and that ganglia is a parasympathetic ganglia, which is called the ciliary ganglia, right? And then that ciliary ganglia will give kind of like parasympathetic motor innervation, and that will go into a nerve called the short ciliary nerve, right? And the short ciliary nerve will make sure your pupil are the nerve that make your pupil constrict. When there's a bright light coming into your eye, your pupil constrict, right? And also the short ciliary nerve will innervate your ciliary smooth muscle, and that smooth muscle is the one that will pull and contract on your lens to make your lens change shape when you read something close, and that's accommodation. So those are the function of your parasympathetic fiber, and from cranial nerve 3. So cranial nerve 3 has two functions, as I said, like motor function, which is the movement of your eye in certain direction, and also the constriction of your pupil, and accommodation. So you can see the oculomotor nerve, cranial nerve 3 is very important because it supplies all the extraocular muscle of the eye, except for two. So the superior oblique and the lateral rectus is not supplied by cranial nerve 3, and we're going to come to that right now. So next cranial nerve is cranial nerve for the trochlear nerve, and as I mentioned before, the trochlear nerve moves exits the brain via the superior orbital fissure as well, and it moves along the cavernosus sinus just the same as cranial nerve 3, and also on the lateral wall of cavernosus sinus, and exits the skull through your orbit through superior orbital fissure, and it supplies a muscle called the superior oblique. So the superior oblique kind of attached to your eye on the lateral side on top right here, and so when the muscle contracts, you kind of pull forward and lateral side like that, so that depresses your eye and push your eye on the lateral side. So depress and abduction. So when the muscle here contract, the superior oblique contract, moves the eye down and outside. So depress and abduction. And what's interesting about the trochlear nerve is that first of all, it's your smallest cranial nerve, right? And what's unique about it, I think, is that it's the only cranial nerve that emerges from the dorsal side of your brainstem. So usually cranial nerve will come from the most of them will emerge from the lateral side or the ventral side of the brainstem. So I think it's just kind of interesting that the trochlear nerve is the only one that emerges from the dorsal side. So yeah, that's cranial nerve for trochlear nerve. So one more nerve about the eye, cranial nerve 6, abducens nerve. So abducens nerve that supplies your lateral rectus of the eye, right? So the lateral rectus is a muscle on the lateral side, and when the abducens nerve tell the lateral rectus to contract, pulls the eye to the side. So the job of the lateral rectus is abduction, like that, abduct the eye. So move the eyeball out. That's lateral rectus, and that's supplied by the abducens nerve, cranial nerve 6, and the function, as I said, is lateral gaze. And same as other ocular nerve, abducens nerve exits your skull via the superior orbital fissure, and it does pass the cavernosus sinus, but it doesn't pass through the lateral wall. So next, let's get into clinical relevance. What are you going to see on your board exams? And usually with the nerve of the eye, what's heavily tested, especially on the USMLE, is about cranial nerve, because cranial nerve carries a lot of functions, right? It supplies most of the extraocular muscle of the eye, and also the intraocular muscle that cause the constriction and the pupillary light reflex and stuff like that. So most of the I can guarantee you're going to see questions about Cranial Nerve 3, and what they like to test about is what we call an oculomotor nerve palsy, or third nerve palsy, right? But before that, I'm just going to run through cranial nerve 4 and 6 injuries. So pretty easy, right? If you have like a lesion on trochlear nerve, cranial nerve 4, the function that it carries out, it will not be able to carry out that function, right? And the function of trochlear nerve superior oblique is down, depress your eye, and abduction, right, down and out like that. So your eye won't be able to, the muscle of superior oblique won't be able to put your eye down and out like that, and that will cause your eye to not align properly. So you will have like double vision and stuff like that. And also cranial nerve 6, if you have a lesion in cranial nerve 6 abducens nerve, what do you think will happen? You're going to lose your lateral gaze, right? You're going to lose your abduction like that. So again, you can have double vision, maybe trouble walking, maybe trouble going down the stairs, or something like that, because your eyes are not aligned. So that's those two injury. And Now we're going to talk about third nerve palsy. But first of all, how do these what causes these cranial nerve injury? So what causes cranial nerve 3, 4, and 6 injury? So a lot of things, right? That could happen in the brain, like a tumor. You can have a tumor that that presses on these nerve, and you can have nerve injury. There could be some kind of pressure in the brain that that presses down on these nerve. You can, like a tumor can cause a pressure, or there could be some kind of fluid in the brain, or some kind of herniation in the brain that compresses these nerves. And also remember I said that cranial nerve 3 passes between two important arteries, right? So above cranial nerve 3 is what? That's the posterior cerebral artery, and below cranial nerve 3 is the superior cerebellar artery, right? So these two arteries runs between cranial nerve 3. Now imagine if there's an aneurysm of one of those arteries, or if there's a hemorrhage of one of those arteries, right? That's going to cause injury or lesion to cranial nerve 3, and then that's going to be some kind of injury to cranial nerve 3. What else can cause injury to these cranial nerve? Infection, right? Infection, and so I said that the cavernous sinus is an area of very high traffic, right? Because all the nerve that I mentioned pass through there, plus internal carotid artery goes through there too. So if there's a thrombosis of the cavernous sinus, that's it's going to cause a lot of injury to these nerves. What else? Where do these nerves exit? It exit your skull via superior orbital fissure, right? So imagine if you have a fracture of superior orbital fissure, like somebody get into a bar fight or something, they get punched in the eye socket, or something that causes like shattering of the superior orbital fissure. That's gonna cause injury to all your nerve that supplies the extraocular muscle and the intraocular muscle, right? What else? Autoimmune disease like myasthenia gravis that causes the muscle to get weaker. That can have trouble with the eye movement. Demyelination disorder, something like MS, So that will cause interrupt of the nerve impulse going to your muscle, so that will cause muscle weakness. What else? Diabetes mellitus. So diabetes mellitus, what happen? It's like when you have a lot of sugar in your blood, and then that ruins your blood supply to your nerve, right? And if your nerve is not getting enough blood supply, that's going to cause some nerve dysfunction. It's not going to be able to send the signal to the muscle fully, and that can cause some weakness of your eye movement. So all these things can cause some kind of injury to a nerve, or which makes movement of the eye difficult, or makes the function of pupil constriction and accommodation difficult. So now third nerve palsy, or oculomotor nerve palsy, you're gonna see it's on the test. I'm pretty sure of it. And in the question stem, you're gonna see in the question stem a clinical vignette about a patient that has drooping of the eyelid. That's called ptosis. So the patient comes in with drooping eyelid, and the patient's eye is down, depressed, and abducted, so down and out. And when you look at the pupil, the patient's pupil, it's going to be dilated pupil. It does. He's got lots of pupil constriction, loss of accommodation, and all that is from cranial nerve 3 injury, and maybe the patient had some kind of stroke or something that would cause a lesion on the cranial nerve, And remember, so the patient will lose all the function of cranial nerves. So remember, the cranial nerve 3 innervates the left palpebral superiorlis, so the eyelid. So that's why the patient will have ptosis, the drooping of the eyelid, and also all the ocular muscle that is supplied by cranial nerve 3 will become will not work. So the only muscle will work will be the superior oblique, that's by cranial nerve 4, and the lateral rectus, that's by cranial nerve 6. So those two are pulling, those two are still contracting. So this one, superior oblique by cranial nerve 4, will depress your eye and move it out. So down and out. And the lateral rectus is still working, still pulling your eye, and that's pulling to the side, that's abducting your eye. So that's why you see the patient's eye depressed and abducted. That's why you see the patient's eye down and out with ptosis down and out. And also cranial nerve 3 carries parasympathetic fiber, parasympathetic motor fiber, right? And if there's a dysfunction of cranial nerve 3, there'll be no constriction or accommodation of the eye. So that's why the patient will have dilated pupil. So third nerve palsy, you can see ptosis, the eye down and out, and dilated pupil. And of course, the patient's not gonna be able to read something close, no accommodation, and also the eyes are not aligned, so the patient's gonna have double vision and trouble walking and seeing and functioning. And finally today, how do you test all these cranial nerves? How do you test cranial nerve 3, 4, and 6? Do you notice when you go to your doctor and your doctor does yearly physical, test your eye, he tells you to look at your finger, and your doctor does the age thing. Yeah, and tell you to look at the fingertip, and does the age thing like that. That's your doctor's testing your extraocular muscle to see if the muscle in your eyes are moving your eyeball smoothly. So through the 4 quadrant, so age, that past the center line, and then your doctor's looking at your eye to see if they move smoothly. So that's testing the extraocular muscles part of cranial nerve 3, 4, and 6. And also the doctor will check for your eyelid for ptosis to see if there's any drooping. And after that, the doctor will check cranial nerve 3 for pupillary light reflex. How does the doctor do that? So shine the pen light through your eye and look to see if your pupil constrict. And also, when shining the light to the pupil on one side, look at the eye on the other side too, because both should constrict bilaterally. So shine the light here, look at the pupil constrict. Shine the light here and look at the other eye to see if they constrict bilaterally. Next, how do you test accommodation? So accommodation is like, telling the patient to look at the fingertip, and you move the fingertip closer to the patient's nose and just tell the patient to look at the fingertip. So when the finger comes closer to the nose and the patient's concentrating on that, the patient's eye the patient's pupil should constrict more and more and more as the finger get close to the nose. And you can check for convergence too. Convergence when you focus on something near and your eyes move closer together. So that's how you check for convergence and accommodation. And of course, when you move your finger out and look at the patient's eye should start dilating again, and the eye should come out. Pupillary light reflex, that's the efferent limb of cranial nerve 3. And did I just tell you how? Yeah, I just told you just now. So pupillary light reflex. So I think I've covered pretty much everything today about cranial nerve 3, 4, and 6 with clinical relevance and how you examine these cranial nerve. And I hope you got something new today. And I want to say, just keep on working hard, keep on doing your Q banks and practice questions. And I'm always there cheering on you. We all need support, and I'm always there by your side if you need me. And the next Tutor video, I think we'll continue with trigeminal nerve. That's going to be a big one because there's so many branches. That's V1, V2, V3 trigeminal. So we'll do that next time. I'm Dr. Chuck with CMC. Thank you again.